Hi class, today we're going to be taking a look at the female reproductive system. The objectives are going to be looking at the anatomy of the female reproductive tract, structure and function of the various glands, disorders associated with the reproductive system, roots, prefixes, suffixes, abbreviations as well, and medical terms in some case studies we'll be looking at. The female reproductive system is comprised of ovaries, which are the female gonads, just as the testes are the male gonads. They're held by ligaments inside the pelvic cavity as opposed to the external testes in the scrotum. Ova is another name for the eggs that develop inside, ova being plural. An ovum is a singular egg. At ovulation, an ovum is released. The follicle that remains behind functions for 2 weeks if there is no fertilization of the ovum. If there is fertilization, it then becomes a secreting gland that functions for 2 months to support the pregnancy. The basic parts of the female reproductive system are as follows. Let's start with the ovary that we just talked about. The fimbriae are the little fingers that receive the ova into the uterine tube and then travels down, and if it's fertilized, implants in the uterus, and if not, comes out the vagina. And the rest of these we will be coming back to as we work our way through the lecture. So the uterine tube we just took a look at is attached at one end to the uterus, and there are arches above the ovary with those projections or fimbriae that have cilia that sweep the ova into the uterine tube. And the uterus itself is a pear-shaped organ where the fetus implants and is nourished during pregnancy. And it's triangular in shape as well, with the cervix at the bottom end. The endometrium is the layer that lines the uterine wall. It has a lot of blood and is placed where the ovum implants. And then a placenta will develop, of which the endometrium becomes a part of. And if there is no fertilization, the endometrium is shed during menses. And the myometrium, should recognize that prefix, is the muscular layer in the uterine wall. So here we have a diagram of the pathway of the ova from the ovary out to menses. So the ovum develops, is swept up by the fimbriae. The endometrium received a fertilized ovum, and the endometrium becomes part of the placenta. In the bottom case, the ovary develops into an ovum, is swept by the fimbriae into the uterine tube. The unfertilized ovum dies and the uterine lining is shed during menstruation. The vagina is where the menstrual flow is transported during menses. It is where the penis is received during intercourse, and is also the birth canal at birth. Okay, here are the roots associated with the female reproductive system. Anytime you see OO, you're looking at ovum or eggs. Salping the root, you're looking at the uterine tube. Okay, so here is the exterior anatomy of the female reproductive system. Here we have the labia majora, and the labia minora. Majora on the outside, minora on the inside, the vagina, vestibular gland opening right at the bottom there. Perineum is this whole area between the anus and the vagina. Mons pubis up top. So as we just saw, the perineum is a region between the thighs and the external genital organs. An episiotomy is to help with childbirth, so the tissue doesn't tear. You surgically make a slice to make childbirth a little easier. And mammary glands or breasts are composed of glandular tissue and fat, of course, for nourishment in a newborn. And milk is made by glands in the mammary tissue. So female accessory organs are as follows. So let's take a look at what happens during the menstrual cycle. So we're looking at the anterior pituitary gland being the main functioning gland in this case. FSH, or follicle stimulating hormone, if you remember that from our last lecture, also is used in the female cycle, causes the ovum to ripen in a follicle, the Graafian follicle. And the follicle itself is the producer of estrogen, and that causes the endometrium in the uterus to get ready for the implantation of a fertilized egg. And again, luteinizing hormone, that should look familiar from the male reproductive system. That what causes ovulation, and at that point the follicle that the egg was being developed in develops into a structure called the corpus luteum. And we'll explain the structure of the corpus luteum as we take a look at the menstrual cycle. So the corpus luteum stays in the ovary, of course, and then starts producing the hormones progesterone and estrogen to help support a pregnancy. If fertilization does not occur, these hormone levels decline and the endometrium is shed during menstruation. So the average is 28 days, with ovulation occurring in the middle of that 28-day cycle. So as we mentioned, FSH at the anterior pituitary gland causes when there is a spike of FSH, the ova is released from the corpus luteum. Then you have a corpus luteum left behind right here that starts producing progesterone and estrogen. And you also have a spike of LH to cause the ova to be released into the uterine tube. Now, as the corpus luteum develops, you can see the estrogen and progesterone levels rising correspondingly along with the development of the corpus luteum. And the effects on the endometrium, or lining of the uterus, are as follows. When the FSH and LSH levels are low, It is thin and not as vascular. When you have the surge of LH and FSH, that stimulates the endometrium to get thicker and more vascular and more hospitable to a fertilized egg. Right there. And then as those estrogen and progesterone levels drop, you start shedding the endometrium and you start the cycle all over again at about day 28. At menopause, the menstrual cycles stop for that person's lifetime. The age in this usually occurs between 45 and 55. Hormone levels in general decline because a woman does not need to support her pregnancy, so she doesn't need the progesterone and estrogen, and the remaining egg cells degenerate. So symptoms are hot flashes, headaches, insomnia, mood swings, urinary incontinence, and vaginal dryness. Things that may help relieve menopause are hormone replacement therapy. It used to be a lot more popular than it is now. Studies found that replacing female hormones can predispose someone to cancers. And then antidepressants to control unstable moods that can be associated with the loss of hormone levels. So if a person decides they don't want to have a child, or a woman in this case decides she doesn't want to have a child, there are several methods. You can stop the sperm from getting to the ovum. You can prevent an ovum from implanting in the uterus. You can prevent ovulation altogether, and you can sterilize in a male. That is the vas deferens being cut in a vasectomy, and a tubal ligation or the uterine tube being cut in the female. So there's the vas deferens being cut at that point right here. You have to do it on both sides to make sure the sperm cannot get into the ejaculate. And in a woman, during a tubal ligation, you need to cut both sides so the eggs never get through to the uterus to be able to come in contact with a spermatozoa. So this is what happens during a sterilization. You have laparoscope with the forceps going in here and doing the procedure, the tubal ligation right there. So here are some key terms you're going to want to keep track of, just professionally and for your quizzes and tests. The cervix is the lower part of the uterus. The clitoris is an erectile body above the urethral opening. Contraception, we just talked about, corpus luteum. Cul-de-sac, that's a term you probably won't be seeing that much. And uterine tube and fallopian tube are interchangeable terms. Fimbriae, the fingers that sweep the ova into the oviduct. FSH we talked about. The greater vestibular gland, or Bartholian gland, at the opening of the vagina. We looked at the majora and minora, and luteinizing hormone and its function in signaling ovulation. Mammary glands, menarche, is the first menstrual period that occurs during puberty, as opposed to menopause, which is the end of the menstrual cycle. Allow me to. Okay. Okay, looks like we covered all of those. So, clinically, a woman can get infections, oftentimes from STDs, sexually transmitted disease. You have herpes, which is viral. Vaginitis is just a general term for inflammation in the vagina. PID, or pelvic inflammatory disease, and salpingitis. Fibroids can cause heavy menstruation, and it can get so big that they start applying pressure to the rectum and bladder as well. Now, fibroids don't necessarily indicate cancer, so keep that in mind. And endometriosis is when you have endometrial tissue that is formed outside of the uterus where it should be. You can have adhesions, because of the endometriosis. You can have pain, dysmenorrhea. You need the laparoscope to get in and remove the tissue that is where it shouldn't be. This is just another cutaway of the female reproductive system. In oligomenorrhea, the flow is too light. Menorrhagia is too heavy. Rhagia is where you get that if you remember that suffix. Amenorrhea, you remember that, is the absence. And dysmenorrhea, dys is the key prefix to look at, and that is when it is painful. And that's from hormone imbalances, and other systemic disorders can show up as these uterine bleeding issues. They pop up a lot at menarche and in adolescence and at menopause. A premenstrual syndrome, or PMS, usually happens after ovulations in that second 14 days of the cycle. A person can become emotionally labile, feel very tired, get bloating, headaches, and have appetite changes. You can use some hormone therapy, antidepressants, anti-anxiety, and rest and self-care, rest and relaxation. Let's take a look at polycystic ovarian syndrome. So when a person has more androgens and estrogens, and because of the feedback loops, it also messes with FSH and LSH because they are dependent on the circulating levels of the hormones. So if you mess with the levels of the hormones, you're also going to mess with the levels of luteinizing and follicle stimulating hormones, and the feedback loop does not work correctly. You can have an or no ovulation and infertility, no menses, hair growth can happen because of the androgens, can become resistant to insulin or pre-diabetic, and obesity can sit in as well as those hormones become imbalanced. And you can treat it with hormones, drugs. Weight reduction will certainly help bring those hormones back into balance. So let's look at a case study. She has cervical dysplasia, and we'll be looking at a technique called colposcopy, D&C, and TAH. So in cervical dysplasia, there are abnormal cells in the cervix. A colposcopy is using an endoscope to look at the vagina and cervix. And you can remove abnormal cells with dilation and curettage, D and C. And she can require a total abdominal hysterectomy or removal of the uterus. So endometrial cancer is the most common female cancer of the reproductive system. A pap smear can certainly help detect it, but it doesn't always work. And you can use both radiation and the aforementioned hysterectomy to treat endometrial cancer. In cervical cancer, there is a very strong link with HPV and with the shot that young people can take now to prevent getting HPV. We should be seeing levels of cervical cancer drop precipitously in future generation. And there are dysplasic or strange-looking cells in the cervix that will be an early indicator that cervical cancer might be developing. And this is diagnosed with the pap smear. And of course, colposcopies and biopsies to verify. Going to have cancer in the ovaries. Unfortunately, it is hard to detect, and there's a high mortality rate because of that. You can undergo an oophorectomy. And remember, OO is eggs, or in this case, the ovaries are removed. Salpingectomy, if needed, if that's where the cancer is. A hysterectomy to remove the uterus, and chemo and radiation as well. So breast cancer is the second leading cause of cancer-related deaths in women in the United States. Since there is so much glandular tissue, the cancer cells can spread rapidly into the lymph system. Early detection is important here with mammographies and MRIs and biopsies to confirm if anything doesn't look right during the mammography. Breast cancer can be treated with a mastectomy or removal of the breast, radiation, chemo, and hormone therapies. You can block progesterone and estrogen receptors and shrink tumors that way if they happen to be of a certain type of tumor that is responsive to hormones. We have some disorders of the female reproductive system. Candidiasis, or the fungus, is the common cause of vaginitis or inflammation and itching in the vagina. Dysmenorrhea, endometriosis. A lyoma is a benign in the smooth muscle of the uterus, in this case the myometrium. You can also call those fibroids. Pelvic inflammatory disease, or PID, is when the infection has spread from the reproductive tract into the pelvic cavity. And often there is a link between gonorrhea and chlamydia in these cases. Salpingitis is an inflammation, again, of the oviduct. Anytime you see the salpin root, you're talking about the oviduct. And it can lead to ectopic pregnancies if untreated. All right, colposcope, DNC. Okay, perimenopause is the period right before and after menopause. That's when the menstrual cycle starts to get irregular before complete menopause, and then a year after the last menstrual period. That's a period of time from the beginning of menopause to a year after the cessation of menses. Oophorectomy we looked at. Salpingectomy is the removal of the oviduct if it becomes cancerous. During fertilization, you have the sperm cell meeting up with the ovum. The nuclei fuse, each parent contributing 23 chromosomes to get the complete complement of 46. At this point, it is a zygote and travels down the uterine tube into the uterus. On its way towards the uterus, it has already started to divide. Once it gets to the uterus, then it will implant in the endometrium that has been prepared by the luteinizing hormone and follicle stimulating hormones, causing the endometrium to get ready for implantation. Then it develops into an embryo, and then finally the fetus. So let's trace this through. So we have an egg developing here, getting larger here, and during the LH and FSH surge, the egg is released, and you're left with a corpus luteum here, which then starts making estrogen and progesterone. The fimbriae are sweeping the ovum up into the uterine tube. And there, it meets up with some sperm to create a fertilized egg. And if all goes well, goes down the uterine tube, starts to divide, and implants in the endometrium of the uterus. The placenta is the organ that's formed from the chorion in conjunction with the endometrium. That's the two parts of the placenta. This nourishes the fetus and supports the pregnancy. And the umbilical cord is the link between the fetus and the placenta. There are two umbilical arteries and one umbilical vein. Two arteries and one vein in the umbilical cord. And there's an amniotic sac surrounding the fetus. So a fetal pulmonary system is different than an adult because it doesn't have to exchange oxygen with the air. So the pulmonary artery is bypassed. There's no reason to send blood into the lungs if it's not exchanging oxygen. Bypass it through something called the foramen ovale. And that is a hole between the left and right atria. And the ductus arteriosus is another bypass that gets blood away from the pulmonary artery and puts it directly into the descending aorta. Now after birth, when the pulmonary system comes online, these holes and bypasses close down. And then you have the completed pulmonary circuit that we studied in the cardiovascular system. So in fetal circulation, we just talked about the ductus arteriosus and the foramen ovale. That's pretty small, but there is a hole between the right and left atria right there. And the ductus arteriosus moving this blood directly into the aorta instead of sending it to the lungs. And we talked about the umbilicus, which has the umbilical arteries, two of those, and the umbilical vein, one of those, right there leading in, connecting the placenta to the fetus. You see the typical head down position of a child in the uterus. And the associated structures, and we have covered all of those. So that is what they look like anatomically. Feel free to stop on this slide if you just want to pull up those terms and commit them to memory along with their anatomical positions. So a typical pregnancy is 38 weeks, and there are 3 trimesters or 3-month periods within a pregnancy. So birth or parturition happens in 3 stages. First of all, you have contractions of the uterus, or myometrium, the muscular part of the uterus, and the cervix dilates to allow the passage of the child, and then the fetus comes out, and the placenta and fetal membranes all come out at the same time. Gravida or gravidus is another name for pregnancy, and para is a person who has given birth to a child. So prolactin causes milk to be let down in the breast. This is also from our friend the anterior pituitary gland, and other hormones that are being produced by the placenta during pregnancy. The release of the milk is stimulated by the mechanical act of suckling on the nipple, and colostrum, and the first few days after birth, is slightly different from milk, primarily because it has antibodies from the mother to help prevent infection in a newborn child. Oh, here are our roots again. And here are some more terms around pregnancy. Not going to worry about the APGAR score. There's another home. HCZ, or human chorionic gonadotropin, that helps maintain the corpus luteum so it can keep producing the hormones, the progesterone and estrogen. And the release are let down in response to oxytocin. And it becomes a zygote once it is fertilized. Once the egg is fertilized. So let's take a look at a case study, familiarize ourselves with some of these terms. So we have AY, she is gravida 2, para 1. I'll just think in your mind what that would mean if you saw that in a chart. He's got CPD and Pitocin associated with her case as well. So gravida means 2 pregnancies in this case, gravida, and 1 birth. So one of those births did not go to term. And CPD is the short version of cephalopelvic disproportion. Now think of what that might mean when you see cephalo or head and pelvic and disproportion. Put those words together. And Pitocin is a drug that will cause the myometrium to contract stronger to help with birth. Cephalopelvic disproportion, I mean, the head is too large to fit through the pelvis of the mother. So if a person has an ectopic pregnancy, you have a fertilized egg that is developing any place outside of the uterus. Most of the times it's in the urinary tube. And any number of things can cause ectopic pregnancies. Inflammation of the urinary tube, overgrowth of tissue outside of the uterus, and pelvic inflammatory disease as well. Some mothers develop hypertension during pregnancy, and it can lead to a very dangerous spike in blood pressure called eclampsia, which needs to be controlled and can be life-threatening. And is caused by the hormonal imbalances that women develop during pregnancy sometimes. Let's take a look at that ectopic pregnancy. They can implant normally, or they can end up in the tube, have a tubal pregnancy here and here, can actually get out, miss the fimbriae and the uterine tube altogether and end up in the intestine, or it could implant way down at the opening of the uterus in the cervical area, and also in rare cases on the outside of the ovary. So abortion is a loss of embryo before the 20th week, or the ½ kilogram weight. And generally, if you have a miscarriage, vast majority of the time that happens during the first trimester. There are cases when the mother might be Rh positive or negative, and the fetus does not have the same Rh antigen. So the mother will make antigen against the child's blood. So you can treat that by giving antibodies to remove the Rh factor from the mother's blood during pregnancy, and then allow a pregnancy to go to term that way. Can have a placenta that is too close to the cervix and can cause bleeding because it can get ruptured if it's not properly positioned. Again, hemorrhaging if the placenta detaches from the uterus. And advanced age in the mother predisposes people to those conditions. The breast can get staph or strep infections and cause inflammation. It can be treated pretty easily with antibiotics. Hang in there, guys. We're almost done. So there are birth defects. You have two types that happen mechanically during fetal growth, or they're inherited from the mother or the father. You have genetic disorders, or there's a change in genes. You can also have other numbers of genes other than number of 46. You end up with things with trisomy 21 would be an example of that case. And a carrier is someone who carries a genetic defect but doesn't exhibit it, and will only be seen if they happen to produce a child with someone who has the same carrier gene. It takes 2 copies of that gene for it to exhibit in the child. It can cause a malformation in the child with alcohol, drugs, chemicals, radiation. Those are all known teratogens, or things that cause malformations in a developing fetus. So some example of what can happen when a fetus is exposed to teratogens. You can have atresia, when body openings don't close properly. You have anencephaly. You see the an suffix again, when there is no brain. Cleft lips and palates. And spina bifida is when the closure over the spine doesn't happen correctly. So here's a example of the spine not closing correctly. In A, that is normal. And B, you see you're missing some here with just a slight overgrowth above that spot. However, you can start having cervical fluid come up through that hole, and nerve tissue can actually also start extruding out into that area. Use amniocentesis, pull out some cells and look and see if they're abnormal. Ultrasonography, take a look at them using sound waves, and sample chorionic villus as well. Let's look at the key terms and see how we've done in covering these. Okay, looks good. We're talking about that Rh incompatibility. We're looking at hemolytic disease in a newborn. We're talking about the incompatibility of the Rh in the fetus and the mother. So pregnancy-induced hypertension or preeclampsia can then lead to eclampsia. Okay, that is everything we have on the female reproductive system. Feel free to reach out to me for any questions you might have. But thank you for looking at these, and I know it was a lot, and you have access to these and the PowerPoints if you want to, if you have anything specifically you want to look at. Thanks a lot, guys.